Hi, I'm Dr. Alison Kole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. Welcome to the Sleep is My Waking Passion podcast. You know who I am. I am your host, Alison Kole, and today with me, I have a real firecracker. I have Dr. Paul Nguyen. He is an interventional electrophysiologist. He is with Elite Cardiology Solutions in Elgin, Illinois. Did I pronounce that okay? Elgin, is that correct?
That is correct.
I'm from Jersey. I'm a Jersey girl. I don't know how to pronounce this stuff.
Yeah,
And
Jersey.
he also is the founder and executive director of a foundation called SCARF. What that means is Sudden Cardiac Death Awareness Research Foundation. This is very important work that he's doing. He is a phenomenal speaker. I was obsessed with hearing him talk at the New Jersey Sleep Society. So I have been nudging him to please be able to make time in his busy schedule. So welcome, Paul. Thank you so much for your time and your expertise. I really think people are going to resonate with your message. So I figured I'd start because one of the things that often happens in medicine is that people kind of come to the doctor and they're like, the doctor doesn't understand anything about my life. They think of us as like, we're here to, provide a service. We're just like cogs in this crazy medical machine. Some people may have foreign ideas about how we are getting reimbursed, and they may have preconceived notions about us, but in reality we are human beings that go through some serious situations. And you had actually shared with the New Jersey Sleep Society that you had been treated yourself for some sleep apnea, even though you're not the classic person that we look for. And you also really spoke about you and your wife's experience experiencing just how serious untreated sleep apnea can be. Can you share a little bit about your, sort of journey and your interest in forming a foundation?
Oh, for sure. Thank you so much, Alison, Dr. Cole, for inviting me to give me this opportunity to really impact community, not just the practice of medicine, but the key thing is information and education. So prior to all of this, my passion was education. So in medicine, if you see it, you do it, and you got to teach it. And if you can't teach it, you don't know it. And I went through fellowship, cardiology, electrophysiology. So we deal with that electrical surgical side to define that life is electricity. Nobody's going to do anything unless you have a pulse. So when I met my wife, who's a dentist, and we looked at so many things, and we realized that no matter what we do in the hospital, in the clinic, but if we don't define and impact what happens when someone sleeps, like for example with sleep apnea, then everything that we do is quite futile. So air is important, and that's our journey. And at this point, we just like to really convey our sentiments and our concerns and keep it simple. I think sophistication is simplicity, and I hope to share that with you today.
Wonderful. So the sudden cardiac death piece you had really emphasized. So can you tell folks, about what that even means?
Yes.
And what are the statistics? And also, how does that tie in with things like sleep apnea, with people stopping breathing when they're going to sleep at night?
Sure. So the bottom line here is that, when we put a stent in or when we deal with patients with a heart attack, there are two different things. A heart attack is when you come in with chest pain, or at times you have fatigue and shortness of breath, that without a good reason, that may be called an anginal equivalent chest pain, similar to chest pain. And people often feel like you have to have chest pain in order to diagnose a heart attack. If I take a female above 65 going into the hospital ER with chest pain and a full-fledged heart attack, and without chest pain, most people will not diagnose that as a heart condition. So they would say you're anxious, you're stressed, you're fatigued. And only 50% of these patients with the heart attack had chest pain. The rest is fatigue and shortness of breath. So we have to define that as well. Cardiac arrest is what happens if you don't deal with your coronary disease or heart disease. Then it becomes an electrical manifestation. that cause a cardiac arrest, and that's why patients need to be shocked out of a rhythm that is deadly called ventricular tachycardia. Everywhere you go, you see that AED, automated external defibrillator, so, literally on the wall, sitting right there or standing right there, waiting for somebody to have a cardiac arrest. But very few of us actually understand, that connection. So there are two different things. Cardiac arrest is majority of times an electrical condition that may stem from a heart condition. And most people blow it off because they have fatigue and shortness of breath and not necessarily chest pain. There's about 550 to 600,000 cardiac arrests per year, and 82% of all adults, females, males, and children, 82% occur while asleep at home.
Wow.
So therefore, that's why the connection of sleep apnea has to be prioritized from the get-go before anything else. That's the first housekeeping rules that we need to define.
Awesome. And you can have several types of abnormal heart rhythms. And
Correct.
You being an electrical physiologist, you really specialize in understanding all of these types of heart rhythms. So you have the deadly heart rhythm, what you refer to as the ventricular tachycardia or ventricular fibrillation. These are really serious abnormal heart rhythms. Life cannot be sustained if you're in that sustained heart rhythm. And there's also something called atrial fibrillation. So I was wondering if you could walk the audience through, these sort of different types of heart rhythms and, kind of how the heart functions and how that would potentially impact your quality of life. Atrial fibrillation can lead to other things that may not necessarily, quote, kill you right away. So I want to state that for the record. We're not lumping them all together. We're sort of dealing with like real bad arrhythmias, and then we have ones that are bad for a different reason, but it's not an immediate cause usually of a sudden cardiac arrest.
Correct. Yeah. So to begin with, we have an amazing organ called the heart, and the heart basically propels itself automatically without plugging yourself into an outlet. And a normal heart rhythm, a normal heart rate is 60 to 100 beats per minute. And it's automatic. And you have four chambers of the heart. You got the right atrium, where is that beacon of life, that automatic rhythm starts. And as it goes down the electrical freeway, your heart beats at 60 to 100. So if you run fast, your heart rate goes up to meet the demands. And if you're relaxing, chilling out, watching TV, it's going to decrease that heart rate so that you can be relaxed and be comfortable. However, certain disease states, such as high blood pressure, can actually dilate the heart, and it dilates the left atrium. And as the left atrium dilates, and that left atrium is on the left side, it pumps blood into the left ventricle, and the left ventricle pumps out to the rest of the world. And some of the audience may know that, hey, my heart function, my ejection fraction is normal or abnormal. So when that blood pressure it increases and it dilates the left atrium, you get atrial fibrillation, which is an abnormal rhythm that actually quivers. And when it quivers, blood doesn't go out to the heart effectively. So therefore, it basically sloshes back and forth, and then it stagnates, and then it forms clots. Hence, a fib requires a blood thinner to prevent that clot from forming, thus preventing a stroke. Certain patients with heart disease that they may not know that have a blockage in the blood vessels that supplies the heart. And if that happens, and if you have a heart attack because there's a lack of blood flow that supplies the heart muscle, that area of the muscle becomes scarred. And if it becomes scarred or it becomes compromised, you may have another rhythm that it's deadly. That's the rhythm that we shock people from, because that's the primary rhythm that can cause cardiac arrest, and that's from the ventricle. So typically, normal heart is top to bottom, but the VT, it starts from the ventricle. It doesn't require anything from the top. It just has a mind of its own. So that's VT, that's the deadly rhythm. AFib is not deadly. if you take care of atrial fibrillation, if you control the heart rate, if you give the blood thinner. Because if you don't know that you have AFib, and if it goes too fast, it can cause the heart, like a muscle, to be weakened. And once you have a weakened heart, there is a risk of a cardiac arrest. So in a nutshell, again, I did mention the number one cause of AFib is high blood pressure. So it's not about diagnosing or treating AFib, it's about preventing AFib and taking
So,
care of your blood pressure.
yes. And so that actually circles back, guys, to sleep. Because
Mhm.
what we know is that if you go to sleep and you're not breathing properly because your upper airway is collapsing, what happens to your oxygen levels? A lot of people kind of know this now, but your oxygen levels fall. And when your oxygen levels fall, your body suddenly goes, hey, hey, things aren't quite right. So even if you don't wake up from sleep consciously and you're not aware of that happening, there are things that are changing. You're activating this fight or flight response that we call the sympathetic nervous system. So what's happening is your body's going, uh-oh, something's not right. I'm going to increase your heart rate. I'm going to increase your blood pressure at night. And sleep is supposed to be restorative. We're supposed to have a calm, low heart rate, just as Paul mentioned when we're sleeping. And we're supposed to have even oxygenation, and our blood pressure tends to dip. We're in a restful state. So what happens when your airway constantly closes off, it's like rest, nope, you're waking up, rest, nope, we're having this surge, rest. And this is happening over and over again every night, potentially for years before we're doing anything with it. And in the end, what we know is all of that overactivation, that abnormal activation at night of our sort of fight or flight adrenaline response leads to things like high blood pressure, which will impact what happens in the heart. And we also know that if you're not getting enough oxygen to your heart, that tends to also sometimes be an irritant. So, as a critical care doctor, one of the most common things I see is when someone's real sick and they're struggling, especially if they have an infection or something, where we're seeing their oxygen levels are low. We saw this a lot even with COVID patients. That's just one example aside from COVID that we see when people get infections and pneumonias and their oxygen levels may be low. It is very common for someone, even if they've never theoretically been diagnosed with atrial fibrillation, I'm probably going to find it in the hospital. It is so, so common to see that linkage. Um, so you mentioned that the muscle can get weak over time. There's a lot of reasons for that. Sometimes it's, the result of having a heart attack that damaged the muscle. Sometimes it is things like people not taking the proper care of their heart or staying in that atrial fibrillation and having high heart rhythm. Can you talk about the link between, quote, heart failure? Because that's really, I know it's a complex topic because a lot of people think, oh, well, I've even had patients who are like, what do you mean? I have high blood pressure. And I see that there's evidence that, yes, their left side functions fine, but it's looking a little stiff. And they're like, well, what does that mean? What do you mean heart failure? Like they're so confused by that term. So can you offer some clarification for that?
For sure. I think going back to, your descriptions of what happens during sleep, and you made it very simple, and I think simplicity is the key. So when you do go to bed and you sleep, that's when we're most vulnerable because nobody's around, no critical care doctor, no uh, electrophysiologist, cardiologist. You have a spouse or may not have a spouse, and that spouse sleeps too. So all of those mechanisms that can cause high blood pressure, hypertension, atrial fibrillation, all of that comes into play at a very critical time when you're suffocating. And literally, just keep it simple, you're suffocating. So when you suffocate, it's like drowning, and drowning is never a good idea, whether it's one time or 5 times or 10 times. It's just a bad thing. So as over time, in and out of suffocation, and luckily we have the mechanism to wake up called the circadian rhythm, and we wake up and we're oblivious to what happened last night. And so, like Alison mentioned earlier, that when you wake up, you're supposed to feel refreshed, rejuvenated, and you're ready to tackle a new day. Unfortunately, day in, day out, it gets you to the point where depression sets in, anxiety sets in, hypertension, and then you get what we call heart failure. So there's two types of heart failure. A lot of people use the word heart failure very loosely, but there is a strict concern about what heart failure is. You have two sides of the heart. One is on the right side and one is on the left side. The left side is very important because that's the big muscle that really contracts and propels blood forward to feed your body. And the heart, believe it or not, has to pump blood out of itself for it to utilize the blood, or else it's trapped into the ventricle. The right side is a low pressure system. There's no oxygen. There's oxygen, but it's lower, and it's venous. So therefore, if you have hypertension, high blood pressure, if you have sleep apnea and not know about it, then that pressure goes up, and therefore the right side, and since it's all there, and if you're a smoker, COPD, all of that stuff, and with emphysema, your pressures in the lung tends to go up. So the lung is right in the middle. The right fills the lung, and the lung fills the left. So if the lung pressures are high, it's going to push blood back to the right side of the heart. So in a way, the right side becomes congested. Your belly and your stomach becomes bloated, and your legs become swollen. So your left side can be pumping nicely, but your right side has been very inefficient. So we see that all the time on an ultrasound of the heart. But sometimes looking at somebody's legs and they're swollen, they're short of breath. When they bend over, they stand up, they get dizzy, lightheaded, and they have 3 pillows that they require to sleep comfortably, or they can't even sleep flat. They have to sit and sleep. So that's a telltale sign that there's a pressure problem. And that's the right side where your ejection fraction, the contraction is normal, and that's right side heart failure with preserved, meaning normal left side function. Then you got the left side. That's where a lot of people focus. But the left side, to me, is much easier because we have a lot of therapy for the left side. So the left side, there's a term called, and I want everybody, on this podcast to remember, called an ejection fraction. I think that number is more important than the Social Security number. The ejection fraction means every time your left side contracts, how much blood is pumped out. Normal is 52% of what's in it. If you're less than that, it can be categorized as heart failure or a weak heart. So if you have an ejection fraction of 35% and somebody says you're in heart failure, there are certain people that needs defibrillator, other advancement in device technology. So low ejection fraction, weak heart, that's left heart failure with reduced ejection fraction. We have a lot of medications for it. We got a lot of device for it. Bypass surgery, transplant, all these wonderful medications. So we have a lot of toys to deal with to take care of patients on the left side. But if we miss sleep apnea, you're just literally giving patients medicine while they're drowning. So you want to take care of the drowning first, then treat the heart failure. I think the predominance in terms of heart failure is right-sided. And we don't have a lot of answers for that. So that's why I'm so aggressive at lowering blood pressure and taking care of sleep apnea. That's the answer for the right side, not just medicine. Well, all of the right side therapy is also overlapping the left. So if you think about it, if somebody, and I hate to say this, it sounds scary. If you have a plastic bag over your face at night called sleep apnea and duct tape around it, your neck around everything to keep it tight, and you can't breathe, does it matter if you're going to treat for heart failure on the left side? It really doesn't matter. And when you treat people like that, and you don't have the plastic bag off, meaning take care of your sleep apnea, your oral appliance, your CPAP, whatever works for you. If you don't do that, then you'll get depressed, anxious, and then people say, hey, you're not compliant with your medicines. It's because you feel terrible. So I think the treatment and the diagnosis of heart failure requires a continuum of making sure that we're not missing anything else that can attribute to worsening heart failure. And at the same time, when we treat the heart failure, we want to make sure that that you got therapy for sleep apnea from the dental side, from the pulmonary critical care side, from the cardiology side. And as the patient, I want you to be your own advocate and make sure everybody talks to each other and to come up with a really simple solution for you. So in a nutshell, that's heart failure. And you know, we can spend months, days, and years talking about heart failure, but to kind of emphasize, heart failure, left side, is the number one diagnosis upon discharge in the United States of America. Number two is that all academic center and all corporate health is looking at heart failure in terms of readmission to dictate the quality of care that the patient is receiving. And 20 to 30% comes back to the hospital within literally 30 days to 60 days. And 50% comes back to the hospital within 6 months of heart failure. And 50% of all heart failure patients die within 5 years. It's a big deal. It is an epidemic that's bigger than all of us. But I think it stems from as simple as, do you have sleep apnea at home? And that's where physicians, we're not very good at it because we're not at your home. But we want to really break down the door. And that's why I'm here tonight, because I know Alison is breaking down the doors and unlocking your front and back to come in and say, I want to save your life. And I think it's a big deal.
And now a quick break, but don't go anywhere. We'll be right back.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleeping coach program, suspect you have sleep apnea, or simply seek a second opinion, she's available for consultations in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 15-minute consultation today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted physician.
If you are liking this podcast, if you're finding it educational, if you are feeling more empowered to go to your doctor with any sleep issues that you might be having to address them, please, please, please lend your support. Make sure that you are liking, following, subscribing. I am available on YouTube. I'm also on Apple, Spotify, wherever you get your favorite podcasts. The website has launched. So we have AskTheSleepMD.com to be your free educational resource. We've added many new blog posts filled with juicy information. If you would like to support the podcast, we now have a way for you to donate. This is a labor of love. I truly enjoy what I am doing. It would be inspiring and truly helpful if you wouldn't mind even so much as donating $1 to keep this podcast going, particularly if you really find this free education a good platform for you and a good resource for you. I also have affiliate links for products that I'm a proponent of, such as Quiet Mind. So please check out the website, sign up, and you will get the latest news, the latest blogs, some sleep tips, and just have a great day and keep listening. Okay, guys, sleep well. I think that is really huge. And I'm going to add to that just by saying the way Paul is explaining this, it's actually, we could spend a long time on this. There is actually a reciprocal situation happening here, meaning what happens too is when you have this untreated sleep apnea and you get to the point where your heart muscle is actually quite weak. The flip side is, because it's not optimal, it actually can cause more issues with how you breathe at night. So then it becomes even harder to treat you when you get to the point of heart failure as a sleep specialist. So what happens is there may be times when what we're seeing is that you get into these funky breathing patterns. If you guys have heard of Cheyne-Stokes, this is, a type of breathing pattern where you breathe real fast and you kind of stop breathing, you breathe real fast and you stop breathing. And it's very classic for heart failure. And the trick is that because the heart muscle is weak, sometimes you can't, you have to be, you can treat the obstruction of the airway now, but then you have what we call this abnormal breathing pattern that's really a, quote, central sleep apnea. So you get into the weeds with things, and then we're more limited, especially with a weak heart, and what we can use to manage that. So it's not that it's not worth treating the obstructive sleep apnea. We just have to be really careful with how we do that because it becomes more challenging. So, really what we want you to do is have a strong heart muscle and not feel like crap as you get older. One of the things that I've emphasized on this podcast in previous episodes is this concept of a health span. Why live to be 100 if 50 of those years are kind of going to be crappy? That's very difficult. If we can have you be healthier for much longer, we can't live forever. That's just the way it is. But can we postpone other issues? Can we postpone heart issues until further down? And one of the key steps here is prevention. Treating sleep apnea when you're in the moment is really adjunctive therapy. We are additional to the medications, to the tricks of the trade that the cardiologists have, the cool gadgets and toys. We're doing something together to manage a condition that now exists. But can we prevent it? Can we save a life? Can we improve the quality of your health? That is so key. I know that we have a few minutes left, and I wanted to go back to the atrial fibrillation discussion, because one of the things that I had shared with you, Paul, as we were talking about this, was we had really tried to emphasize to our patients in the practice that I was in the importance of looking for sleep apnea when you have atrial fibrillation, because the newer data suggests if we can get you out of that type of heart rhythm, we might be doing something good for you. And one of the techniques that we use for that may be to go and we do what we call an ablation, where we sort of zap the areas that are contributing. And what we know is that if you don't treat the sleep apnea, some of the procedures we do is less successful. So I figured we might be able to finish off with a little discussion about, there's a treatment for, AFib and how that ties back to sleep apnea.
You bet. And AFib, as you know already, is not just a rhythm issue by itself, but the journey of AFib is a stroke risk, it's a heart failure risk, and eventually a cardiac arrest risk. So it's a big deal. And I believe that AFib is preventable. The bottom line here is that, both of us, I'm pretty sure that we're treating adults. But I think that this podcast is very powerful is because children, young adults, teenagers should be really listening as well, because we never talk about prevention. We're pretty good treating after the fact because it's easy, because you know what it is. But for the patient, they've lost. You have to be hospitalized. You have to go through procedures. There are complications. And so therefore, we are well trained to do these procedures, but the complications exist. And if we don't uncover sleep apnea, then the preventive side after receiving the procedure, the outcome may be iffy and the recurrence rate is high. So atrial fibrillation is a stroke risk, like I mentioned before, and there's 3 types, right? And there's 4, and we can go into the details, but just to keep it simple, people who have AFib that goes in and out, that's called paroxysmal AFib. You're in and out of it, episodic. Persistent AFib are the ones that are staying in AFib all the time until we shock them out or we give them medicines to get them out of it. And then permanent AFib is no matter what we do, we're giving up. There's no way we're going to get you back to normal rhythm. AFib is not a death sentence. It is a rhythm. If we can control the rhythm, even despite you being in AFib, you're fine. If you're resting and your heart rate's 60 and less than 100 normally, that's fine. And if you're jogging and it goes up to 120, 130, 140, 150, and it backs off when you're resting, that's a normal response. You just have to be on blood thinners, and that blood thinner depends on, are you at risk for a stroke? And there's a CHAD VAS score that I think that subsequently we can talk about it. The cardiologist will add up the score. And if you're a female, if you have a score of 3, that takes into account with diabetes, hypertension, stroke, age. And if you have a 3, then you should be on a blood thinner. If the dudes have 2, then you have to be on a blood thinner. So it's such a crude measure, but no matter what measure it is, your doctor should know you not for 5 minutes, but there should be a relationship to where they understand you, so that when they make that recommendation, it's just not guideline based, it's relationship based as well. That's how you safeguard your patient. The only thing that the CHAD-VAS score doesn't have, Allison, and I think we should fight for it, we should put sleep apnea as part of the CHAD-VAS. There should be 2 S's instead of 1. Right? The S stands for stroke. The other S should be sleep apnea. And I think that's what we should fight for. I'm a policy-based guy. So now, if you are a candidate and you have atrial fibrillation, now we have certain curative measures. But really, to be honest with you, there are no curative measures, because one of the risk factors for AFib is age. And you and I both know we can't stop aging, right? So if you have AFib, we can control the heart rate, called rate control, with medicines like a beta blocker, metoprolol, cardizem, digoxin, or we control the rate, and we can control the rhythm with certain antiarrhythmic medicines that you can discuss with your cardiologist. So we have to sort of do a combo effect. And then on top of that, if you meet the requirements for a blood thinner, you can do that too, because the last thing you want to do, like Alison said it very well, live long, but you have to live well. There's a quality of life issue as well that we still have to harness and protect. Quality of life starts from day one, and it ends when that day comes, that inevitable day. But in between, longevity, you're on your own, but the quality we always have to keep as a priority. So medications to slow down the heart rate to prevent AFib. And if you become more symptomatic, we can actually cardiovert you, shock you out of that, and stay on the medicine. If all of that doesn't work and you're sitting down with your cardiologist and electrophysiologist, and we feel that the next reasonable step would be an ablation, then you would be evaluated. You would go to a cath lab or an EP lab. We would put little small catheters into the heart and define where AFib is. We can map all that out and go from the right heart to the left heart. And AFib is in the left atrium. That's where the garage, that's where AFib lives. And there are 4 pulmonary veins, and AFib is trapped in there. And if it comes down, it can misbehave, and it goes fast and it can go slow. AFib can go fast and slow. So if you are an ablation candidate, we can actually map it out and zap it with radio frequency, or, believe it or not, with very, very low temperature probes. And if we can hurt that circuit, we can actually prevent AFib from actually affecting you. It's trapped in the left atrium. It's always there. It's in the pulmonary veins. It's always there. But the ablation prevents that from coming out to affect your quality of life and even your longevity. The risk of ablation is very minuscule, about 1% in terms of harm. And the recurrence rate can be up to about 25%. So it's never 100% cure. But if we deal with preventive measure, like preventing suffocation by diagnosing sleep apnea, taking the plastic bag off of your face at night, then we can literally prolong the success of preventing AFib after ablative therapy. And do you do it once? Some people need it twice or even 3 times. But I think if you're a candidate, I want you to sit down with your cardiologist and electrophysiologist and ask a lot of questions. And if people can't answer your questions, then that's probably not the place that you should be for an ablative therapy.
Yes. And guys, the take-home message here is we are very heavily focused on sleep apnea. And we can get into a whole other discussion about disrupted sleep. There's other causes for that. And there's other conditions that affect our sleep that may impact our heart. But our goal here really is to at least get you to see, don't ignore the sleep apnea. And, you can wax intellectual, but well, that study showed that it's, if the X number of events occurs, then that's a problem. There's a lot that we don't understand about apnea that goes beyond just how many times it's occurring. It also is how low your oxygen levels are occurring. And there's going to be more and more information coming out as we learn more, basically. When you think about sleep medicine, it's relatively in its infancy. I mean, right now we're really learning so much, and it's one of the reasons I'm so excited about this field. So, Paul, I really, truly appreciate you sharing your expertise. If you guys are interested in learning more about his foundation, go to his website. Do you want to say anything about the foundation as we have our final words?
Yes. Before all of this, I just want to let you know that nobody knows that they actually have sleep apnea. So when you have certain condition, just go get tested. When you're sleeping, you're vulnerable and you're oblivious. So you don't have to feel that you have sleep apnea. I didn't know I have sleep apnea. I'm 135 pounds, right? So I'm the atypical person. So when in doubt, mindset, depression, ADD, heart condition, palpitation, go get a sleep study. Bottom line. And if the first one is negative because you didn't sleep, that doesn't mean you don't have sleep apnea. It's because you didn't sleep to have apnea. So that's the first thing. Sudden Cardiac Death Awareness Research Foundation is my life, my passion. We've gotten hundreds of kids to higher education. And the goal here is to impact community by information and teaching and keep it simple. So I'm hopeful that one day the kids that go through becomes the Dr. Nguyen and Dr. Kole of our community, that they're reinforced by not just good doctors or compassionate doctors, but they're able to resonate their information and education to help their community to be safer. So safety is first, secondary is health. But I thank you so much, Dr. Kole, for giving me that opportunity to share my passion with the community. Thank you so much.
Absolutely. Bravo. Bravo. Loved it. Thank you. Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.